Hello, dear friends. This is Dr. Anshum Arora, and today Pulmonology Read Aloud is back with the much awaited Pulmonary Hypertension series. Now, why I'm calling it a series is many of you have requested for the Pulmonary Hypertension guidelines, but this is a long document and it's impossible to complete it in one video with clarity. So I've broken it down into 3 parts, and I will be uploading the parts in regular interval over the next 3 to 4 weeks. Today we are starting with the definition, the group classification and symptomatology and signs of pulmonary hypertension. So without any delay, I'm going to start with the video. Now this is the guidelines that I've referred to. These are 2022 guidelines, so the latest guidelines, and these are joint recommendations by European Society of Cardiology and European Respiratory Society. So these are very helpful and they try to break down this very complex topic into much simplification. So my job here today is to go through the most important points in these guidelines, and as you see, it's very well laid out, a lot of chapters, so you can actually go through them and read everything in detail. But today what I'm doing is today I'm going to discuss what matters to us as pulmonologists most, and even my topics would concentrate most on what as pulmonologists we must be doing and we must know. So let's look into the guidelines with respect to the definitions. Now, so remember that when we are talking about pulmonary hypertension, there are a lot of hemodynamic measures that are being mentioned, and classically all of these are defined by right heart catheterization. So direct measurement of the pressures by right heart catheterization gives us the most accurate diagnosis of pulmonary hypertension, but we know practically that every patient may not have a right heart cath done, and so we try to use echo data and other data to interpret our readings. So we'll talk about that as well, but whatever measurements I'm mentioning here are right heart cath measurements. So to define pulmonary hypertension, one thing that has to be remembered is that the guidelines in 2022 have laid a cutoff of 20 millimeters mercury mean arterial pressure. Now, if you remember, the earlier guidelines used to talk about 25 at rest, but remember now pulmonary hypertension will be defined by a MAP, or a mean pulmonary arterial pressure as measured by right heart catheterization, more than 20 millimeters mercury at rest. What's also important in this year's guideline is that they have divided the definition on the basis of the phenotype or the etiotype of the pulmonary hypertension. So if you divide pulmonary hypertension based on the etiology, you can basically divide it into a pre-capillary pulmonary hypertension, an isolated post-capillary pulmonary hypertension, CPC or combined pre and post capillary pulmonary hypertension, and exercise induced pulmonary hypertension. And now this is a very simple definition, just look into it closely. You need a mean pulmonary artery pressure of more than 20 to define PH. When you talk about pre-capillary, and what it means we'll just discuss in the next slide, but when you talk about pre-capillary, along with the mean PAP raised, you should have a raised pulmonary vascular resistance but a decreased pulmonary artery wedge pressure. So rather a normal pulmonary artery wedge pressure which is less than 15, but just the mean pulmonary artery pressure is raised and the vascular resistance is increased. If you talk about isolated post-capillary, then something to note is that here the wedge pressure increases. So how do we distinguish? The wedge pressure increases in a post-capillary and the resistance reduces to less than 2 Wood units, but yes, obviously the mean PAP will stay high. Simplified. Now we go to the next one, which is combined. So as it shows if it's combined, you'll have all of the three. You'll have a higher pressure, you'll have a higher wedge pressure, and you'll also have higher vascular resistance. So that's combined for you. And what is exercise induced? Here they measure a slope. They measure a slope between mean PAP and cardiac output. And if this slope between the rest and exercise rises more than 3, so normally it does not rise to that level, but if it rises more than 3 on exercise, then it's called a exercise pH. And there's one more terminology which is added to it, which is unclassified pH, and it's not in the table given here, but where the parameters are not in accordance with this. So patients who will have a high mean pulmonary artery pressure, but they would have a lower resistance, and even the pulmonary wedge pressures, artery wedge pressures will not be high. So this is kind of not fitting anywhere, and they call it as unclassified. Now quickly, what does this all mean? Very simple to understand. Anything happening before the lungs, anything happening before the admixture at the alveolar level is precapillary. Anything happening after this is postcapillary. So precapillary is arterial and postcapillary is venous causes. So this is broad division, and you look closely further and you look at this beautiful picture from current treatment strategies in hypertension. This is a lovely paper on pH. Now you look here, this is the pulmonary capillaries. So anything happening before that, so whether it's happening at the level of the pulmonary trunk, in the artery itself, the right heart, it's precapillary. So here your flow will be good. So it will be a high flow pH. So the resistance is normal because the flow is not affected here. It's just precapillary. Anything which is happening after this, so will be pulmonary venous or left heart. So this alone would be isolated postcapillary, and things that combine this as well as this will be combined post and pre-capillary or mixed, right? So again here, so if it's pre-capillary, your wedge pressure, let's revise, will be normal, will be less than 15, your resistance will be high. And if it's post-capillary, isolated post-capillary, here the wedge pressures will be more, the left ventricular pressures will be more, the resistance will be low. And if you combine pre and post-capillary, here both the things are happening, the cardiac filling pressures are more, the wedge pressures are more, the resistance is more. And it is here that we usually define into vasoreactive and non-vasoreactive to look at response to drugs, which we'll come to later. So why are we using these two criteria? They were not mandatory criteria earlier, but why you are using these are because they are helpful criteria through which you can distinguish broadly whether it's happening because of pulmonary vascular disease or whether it's happening because of left heart disease or lung disease or intrathoracic pressure. And normal pulmonary artery wedge pressure is 12, but the data is not same uniform in all papers. So the guideline accept that there is a discrimination between the ranges. So this is the best possible that they could use, but this can change in future, and we may have in future guidelines which refer to different level. Now let's come to the next part, which is unclassified. As I said, the pressure is high, the resistance low, the wedge pressure is also low, so you don't know what's going on, what is the site of affection. So this is unclassified. Usually you may see it in patients with heart diseases, lung diseases, liver diseases, hyperthyroidism. So basically anything of this sort can also happen in these patients. Okay, so this is how you remember this. If none of this is met, then it's unclassified. Exercise pH, we've already talked about it, and we'll talk about later when we speak on cardiac catheterization. So the classification. So 2015 classification, which was the last update, divided pulmonary hypertension into 5 major groups. You'd remember that the first group of pulmonary arterial hypertension was further divided into idiopathic, heritable and associated with certain factors, and then there was a 1- with veno-occlusive disease and persistent pulmonary hypertension of the newborn, and then the rest of the groups were divided. Now what's changed now? There are a few major changes. Again, there are 5 groups. So what is the classification? 5 groups. Broadly, first is arterial, so pulmonary arterial, so pre-capillary. The second is left heart disease, isolated post-capillary. The third is lung disease, which could be combined. The fourth is pulmonary artery obstruction. And the fifth one is multifactorial or unclear. Now what has changed here is, in the first group, the group 1, they've divided idiopathic into 2 varieties with non-responders to vasoreactivity testing and acute responders. So basically it has more clinical implication with means of the treatment that you'll give. So they've classically divided it so that you know that this testing is very important. So idiopathic, they've divided into 2. The other change is that they've included pulmonary venous and capillary involvement in the same. So the 1 dash goes away and 1.2, 3, 4 and 5 comes in place. And even the 6th one, the persistent pulmonary hypertension of newborn, has come into it. So the heritable one is included, and the newborn is included in classification, and the venous is also included, so in the group 1 itself. And what has also changed is that if you look at the group 3, which is of a lot of interest to us, they earlier used the term sleep disordered breathing, and now they've replaced it with hypoventilation syndrome in group 3. That's because not all snorers or not all OSA patients will generally have PH, so they removed sleep disordered breathing. But PH is significant or frequent in patients with hypoventilation syndrome, patients who have daytime hypercapnia. So they've changed the terminology, which is very well welcomed. So again, broadly, just so that it goes into your memory, you remember that group 1 involves the right heart and the pulmonary artery pre-capillary. Group 2 involves the left heart, so post-capillary. Group 3 involves at the alveolar level the lungs. And group 4 could be pulmonary obstruction, so pulmonary embolism. And group 1 dash, which was there earlier in terms of venous, has been included in group 1 proper. Now, a very significant table, something that clearly summarizes most of pulmonary hypertension. You take a screenshot, very good for exam goers to generally just go through pulmonary hypertension at a glance. So it talks about the prevalence. It's not very common. Globally, prevalence is around 1%. But remember that post-capillary and pre-capillary are 2 forms that you can divide. Ultimately, there's a rise in mean PAP, there's a rise in pulmonary vascular resistance, and there's a right heart failure. If you divide it clinically and not through pathogenesis, you can divide it into pulmonary arterial hypertension, left heart, lung, obstruction, and unclear mechanisms. Pulmonary artery hypertension could be idiopathic, it could be heritable, and there could be associated conditions. It is not very common, at least the idiopathic variant is not very common. It is rare. And here medical therapy mostly that we talk about, the PH drugs, are indicated in pulmonary arterial hypertension. They act here. So here you have to look for responders to give them calcium channel blockers, and they could be candidates for transplant. When we talk about left heart disease, the post-capillary isolated or combined, that is very common. So what this tells us is that if you're seeing a patient with pulmonary hypertension, the first thing that you must rule out is that is it because of a left heart disease. So there the echo is so important, and a cardiology liaison is very important. So if it is isolated post-capillary, you treat the left heart disease. And I recently had a patient who had a young patient with global hypokinesia and ejection fraction 15 to 20% reported to me with hemopsis, and I diagnosed it as pulmonary hypertension, but later on it turned out that when we were trying to figure out the cause of pulmonary hypertension, it was actually left heart disease. So that's the majority, so please rule it out. Treatment would be treating the left heart disease, and it will help most of the patients. And if it's combined, then potentially you could try some drugs for it. So again, and patients can be enrolled in trials. If it's lung disease related, which we usually look out for as pulmonologists, then it could be either severe or non-severe. Is it common? Fairly common. So that's why we have to look out for it, but definitely less common than left heart disease. And here again, the lung issue has to be optimized. And then you could, in severe cases, you could give them few drugs. If it's pulmonary artery obstruction, it could be either chronic thromboembolic or acute embolism. Not very common if you say, but yes, we do see cases as referral centers, but it's rarer compared to the other two. Surgical therapy is the best therapy here. It could be pulmonary endarterectomy, it could be interventional balloon dilatations, and sometimes medical drugs. And the unclear mechanisms are common in hematological disorders, in systemic disorders, in sarcoidosis, but it is a rare variant, and again you need to treat the underlying condition. Coming back to the classification, I'll be talking mostly about group 1, connective tissue disease related, and group 3 and group 4 in my future talk. So this will be our main focus. We'll try to avoid the left heart disease because this is going to make a discussion too long, and we're going to try to avoid things that we don't see so routinely, but very much in the classification, and please go through it for completion of the subject in the article. So let's talk about the first group, which is PAH or pulmonary artery hypertension. These are just brief pointers. We'll be talking about this in detail in my third talk in the series when I talk individually about these diseases. So how common is it? Almost 6 cases a million is the incidence, and 48 to 55 million per million adults is the prevalence. So it is not very common. It mostly affects females, but there has been recent data where elderly along with cardiovascular comorbidities, they've been found to have pulmonary arterial hypertension. So we must remember that it's not just females. Now the gender equivalence is coming back. The idiopathic is the most common variant in almost 50 to 60% cases, but as we said, some PAH may be associated with connective tissue disease, which is a large area of interest for us, and so it becomes very important. Congenital heart disease and portopulmonary hypertension, and also with drugs and toxin related. So definite association with these. Now in the drugs and toxin related, it's a very good topic for Viva, for exam going students, but there's a definite association with dexfenfluramine, fenfluramine, nasal decongestants, which were banned because of this effect, methamphetamines, amphetamines, aminorex, and dasatinib. So again, immunomodulatory therapy and TNF-alpha blocking agents, you could have a high definite association. What's also important for us to remember is there's a possible association with cyclophosphamide, mitomycin C. We're using a lot of cyclophosphamide in connective tissue disorders, and so we have to know that this is a possible side effect of the drug as well. Amphetamines, bosutinib, the drugs, cocaine, antivirals also. Some Chinese herbs have been directly implicated, leflunomide, rheumatoid arthritis patients. So pulmonary hypertension can occur as secondary to the lung disease, but can also occur because of the drug itself. Phenylpropanolamine, I was talking about the decongestants, and protease inhibitors, etc. So this is a good list, and this has to be kept in mind. The other group, the second group, is with left heart disease. Almost 80% patients with heart failure who are elderly, they will have some form of pulmonary hypertension. It could be post-capillary or combined, and it increases when you have valvular heart diseases. And even in symptomatic mitral valve diseases, almost 60 to 70% will have some form of PH. So very important to rule that out. The third group, lung diseases and hypoxia. Whenever you deal with an advanced ILD, some mild PH is expected will occur. You may have moderate pulmonary hypertension up to the tune of 35 to 40 in almost 5% advanced COPDs, chronic respiratory failure, patients who have advanced disease so much so that they are going for lung transplant surgery or bronchoscopic procedures for COPD. Again, PH, pulmonary hypertension is present, so rule that out. Patients with IPF, around almost 15% patients on the initial workup will be found to have hypertension, pulmonary hypertension. and as the stage of the disease increases, the incidence increases. And another category is mountain sickness. So again, high altitude dwellers may have more pH, but there's not enough data to see whether or registries to say that what is the extent, but there have been reports. Coming to the fourth group with pulmonary artery obstruction, it can be chronic thromboembolic pulmonary hypertension. Usually the acute embolus would cause a sudden increase and rise, but CTPH leads to pulmonary hypertension. Usually patients who have pulmonary embolism, they remain dyspneic after treatment. They also have CTPH, prevalence of 26 to 38 cases per million adults. And the last group is multifactorial. It could be both pre and post capillary, and sarcoidosis is one illness that interests us where group 5 pH may be present. Quickly scrolling through these symptoms and signs. So just few slides, the last few slides now. Symptoms, basically early on patient will just complain of dyspnea on exertion. He may be fatigued. You try to ascertain the cause. You don't find a primary cause. Look for pulmonary hypertension. He may have palpitations. Hemopsis. One of my patient recently had a hemopsis lasting a month, on and off, mild hemopsis. Turned out to be pulmonary hypertension without any lung involvement. Exercise induced abdominal distension and nausea. So in exercise induced PH, fluid retention, heart failure causing weight gain or syncope. And rarely some may complain of chest pain, some may complain of dysphonia because of Ortner syndrome, and they may also have other lung related complications. Signs, if you remember classically, what you've read is a raised JVP, parasternal heave, palpable P2 and loud second heart sound or P2 sound as a sign of right atrial enlargement or pulmonary hypertension. But if you look for other signs, cyanosis may be present. You may have a third heart sound, you may have a murmur of tricuspid regurgitation or pulmonary regurgitation. There may be signs of heart failure, so we'll have abdominal distension, ascites, hepatomegaly and peripheral edema. For patients where we are trying to look for causes, they may have clubbing, so rule out heart diseases, rule out fibrotic lung diseases, bronchiectasis, Eisenmenger syndrome, differential clubbing. You can get crackles, you can have certain murmurs as I said. And in patients who have a chronic thromboembolic pulmonary hypertension, look out for DVT, look out for sclerodactyly Raynaud syndrome in patients suspected of connective tissue disease. And for right ventricle forward failure, again peripheral cyanosis, dizziness, pallor and cool extremities may be few of the important signs. So very important points on examination. ECG, I'll just dwell on it for a few minutes. ECG, you may get typical abnormalities in pulmonary hypertension, mostly P pulmonale, so right axis deviation, signs of right ventricular hypertrophy, right bundle branch block, strain pattern, and sometimes QT interval changes. So here you can see evidence of right axis deviation. So you have deep RS and complexes in the lead 1 here. Right ventricular hypertrophy, you look at tall R waves, right atrial enlargement, you can see strain on the right atrium, so P pulmonale, and right ventricular strain pattern here with the ST segment. So this is something that you may notice. Let's look at one more example. Right atrial, right axis deviation here, right ventricular hypertrophy, tall R waves and RV strain pattern. Also, sometimes we try and look in pulmonary embolism and patients with pulmonary hypertension. You may look for certain signs like S1, Q3, T3 sign. It's a good sign to remember, but S1, Q3, T3 pattern may be rare. You may get deep S waves in lead 1, Q waves in lead 3, inverted T waves in lead 3 in a case of pulmonary embolism, and he may later on go on and develop a chronic pulmonary hypertension. Radiographic signs, X-rays usually showing prominent pulmonary conus, signs of right heart enlargement, pulmonary artery enlargement, prominent vessels, pruning of the peripheral vessels as we see here, and a water bottle shaped heart in case of left atrial enlargement as well. And CT scan, so before we go to CT scan, just basically enlarged cardiac apex, enlarged right atrium, pulmonary outflow tract prominence, enlarged arteries, pruning, and you could see other signs of the underlying illness which could have caused the pulmonary hypertension. CT scan, you can't miss this, enlarged pulmonary trunk more than the diameter of the corresponding ascending aorta. So these are the few signs and symptoms that can help establish a suspicion of pulmonary hypertension. In my next video, we'll be talking about the diagnosis, which includes vasoreactivity testing, and I'll simplify that as much as possible for you to understand. We'll be talking about 2D echo findings and parameters and the rest of the diagnostic measures. So keep tuned and look out for my next video. Please go through the guidelines. There are a beautiful set of tables, graphs and flowcharts in the guidelines. And see you later. Happy reading.